Hey everyone, welcome to Joffrey's Asynchronous Anatomy class. I hope that this kind of setup gives you a little bit more flexibility with taking the class. So today we are going to review the planes that we've already talked about in the last class, but we're also going to go a little bit deeper, so exploring movement that's related to these planes. We're also going to talk all about bones and review injuries, as well as give you a couple new ones that we didn't go over in our first section of class. Diving right in here, the skeletal system is composed of all the bones of the body, related cartilages and ligaments, and the joints that connect these bones together. So it's not just the skeleton, it's everything directly related with it. We've already seen this slide, but going over it again, because it's kind of hard to learn if it's your first time. The photo on the left is the green rectangle, the transverse or horizontal plane. This divides the body into upper and lower portions. The middle picture with the red rectangle is the coronal or frontal plane, dividing the body in front and back halves. And the sagittal plane is the blue rectangle on the right, the vertical plane dividing the body into left and right portions. How does this relate to dance? So starting with that sagittal plane, again, this is the plane that divides the body into right and left halves. So basically anything related to extension, flexion, right? All related to the sagittal plane. So if you're moving in this way, that is naturally the sagittal plane. Movement in the coronal plane, think about like in a modern class when you're on your floor doing those lateral warm-ups. That is abduction and adduction. That's the frontal or coronal plane. By the way, I've also labeled where I pulled these drawings from the Clippinger textbook. Page 19 was the sagittal one, and this is page 20. So you can reference that in your textbook on your own time. Movement in the transverse plane is any sort of rotation, whether it's supinating the hand, pronating the hand, even a pirouette, any sort of rotation happens in the transverse plane. And you will need to know that for the exam. Primary tissues of the body, starting with muscle tissue. This is characterized by its ability to contract. Nervous tissue, these are cells or neurons that can conduct electricity, reminding you of that nervous system that we went over in our last class. Epithelial, which is skin, it's the cells that create continuous sheets or membranes that cover and line surfaces of the body and form glands. And then there's connective tissue that binds, supports, insulate, and protect structures. This is cartilage, bone, and blood. Ligaments connect bone to bone, and it's a short band of tough, flexible, yet fibrous connective tissue. And its job is to stabilize the joint. Tendons connect bone to muscle. Yeah, so ligaments are bone to bone. Tendons are bone to muscle. These have more flexibility than ligaments. They absorb impact as muscles spring into action. Ligaments, once they are stretched beyond their regular length, they actually stay in that length. And tendons can actually go back to that original length within reason. Functions of bone, you will probably have this on your exam. Support, give shape, protect, assist in movement, blood cell production, and mineral storage. So your axial skeleton pictured on the right is what we kind of consider our trunk plus our skull, right? And our appendicular skeleton is all the items from that pelvis and all those attachments like arms and legs. So this is a pretty I actually reference this a lot in my class. You do need to know what it is. Axial skeleton, again, is the trunk, and appendicular skeleton is all the attachments. All right, Wolff's Law from Karen Clippinger's book, page 5, quote, changes in the internal architecture of bone and the external form of a bone occur in response to the magnitude and direction of forces acting on bones, end quote. Now, what does that even mean? How is that applicable to you as dancers? So in other words, healthy bones are highly responsive to weight bearing activities and muscle contractions. And the type of training impacts our bones and what they look like. So a swimmer's bones are going to look different, and they're going to have a little different build than a runner's bones, right? The swimmer is doing no impact training in the water, just working against a little bit of gravity and resistance with the water, whereas a runner is in a high impact mode of training. So those bones are going to look a little bit different. So you remember how in our previous lectures about, shin splints, for example, how changing the training or changing the floors in a really quick sort of way without easing into it. This is why, because the bones don't have enough time to adjust to the different types of floor or intensity or rigor of the training. Types of bones include, starting with long bones. So we're looking at our humerus bone, which is our arm bone up here. We've got the radius and ulna bones. We've also got our thigh bone, which is our femur. And we already learned the tibia and fibula. The fibula is the smaller one, even though it has more letters in it, it's the smaller bone. That's how I also remember it. So long bones are tubular in shape and much longer than they are wide. And this is most of the limbs of the body. Pretty self-explanatory. So I'm just going to give you a second to label these for yourself. Okay, so now that you've had a second to look at it, this is an anterior or front view of the body. We've got the femur bone here, and then we've got our tibia bone. And then the fibula bone, again, is that smaller bone that's also on that lateral or outside part of the lower leg. And what we're looking at here is, this is an anterior view of the right shoulder girdle and arm. And I can tell that because of the way the clavicle, this is the clavicle here, comes out in front. And then the scapula, this little triangular bone that we'll talk about later, is kind of scoops around to the back. So this is our humerus bone. And then this can be a little tricky, ulna versus radius. So a little trick to help you learn about that. You can just do this with me, or you can just watch. Your ulna is connected. You can palpate it on yourself. It's here and it connects to your little finger. Yeah. And then the radius radiates or rotates around that ulna. So if I'm like palpating my ulna bone here and I pronate, you'll feel that the radius is moving, but the ulna stays the same. It's in this same relationship with the elbow joint, and the radius rotates and crosses over as the hand pronates and supinates. So to identify which one is the radius or ulna, you can always find that the ulna is the one connected to the smallest finger. So this one here on the right is the ulna bone, and the one on the left is the radius. Can be kind of tricky. Short bones, these are cubical in shape and found in the upper portions of the hand, which is carpals, and the foot, which is tarsals. That can be a little confusing too. These bones are for small, complex movements and stability. So we have the hand in this picture on the left with all these little short kind of bones that all kind of come together to form this hand that can rotate and move a lot, right? And then the short bones of the feet here, also a huge amount of stability here. If you think about how much the foot is responsible for our navigating the world, these bones are small but mighty. Flat bones, this includes, we've got the cranial bones, we've got the sternum, this is a scapula, and we've got the ribs. So these are relatively thin and flat and slightly curved in shape. And they protect important soft underlying structures like the brain, for example, like the heart in the sternum and the rib cage and even the scapulae. And they also have a large surface area for muscle attachments. So again, looking at that sternum and how there are all these little attachments here where the cartilage from each rib connects to that sternum. So it has that really, really large surface area. For a scapula, there's all sorts of rotator cuff muscles, and the shoulder is very, very complex to be for a later date. But there's a ton of muscles attached to it. So that's flat bones. Big surface area. Irregular bones, these have various functions that are often enhanced by their specialized complex shapes, like the spine, for example, or the sacrum, here pictured on the right. This is the end part of your spine. Sesamoid bones, these, we went over this a little bit with the patellar tendon, with the patella inside of it. These are bones that form within a tendon. And there's one other sesamoid bone in the body, and it's in the big toe, and it's under that first metatarsal. So those are the two sesamoid bones in your body. They help to protect tendons from excessive wear. And they also change the angle of the tendon so the associated muscle can produce a more effective force of movement. So I was always like, what does that mean? But if there wasn't a tendon where that patella was formed within that tendon, it would not be as effective for running, for lifting weights. It kind of just keeps the knee on track, and it makes it able to be more load bearing, right? All right, types of joints, starting with fibrous joints. Articulating bones are joined directly with fibrous tissue. Examples include the sutures of the skull and the middle of their radio-ulnar joint, that space between your radius and ulna, your radius and ulna. There's fibrous tissue that connects those bones. Cartilaginous joints, that's a fun word. So these are the bones that are joined directly by cartilage. Examples are the intervertebral discs of the spine. So without these discs in between each vertebra, there would just be bone on bone. So you'll see that in a lot of older people, particularly in women, the bone starts to break down, or maybe you've heard of like a slipped disc, and then it's bone on bone. So that's a cartilaginous joint that relies on these other cartilaginous cells, structures, to be part and support that bone structure. Synovial joints, your knee is a great example of a synovial joint. The bones are not directly joined and are separated by a joint cavity that contains synovial fluid. I'm not going to go into too much detail of this. I don't think you need to know much more than the fact that it's a synovial joint. Common bone injuries, again, this is mostly a review for you since we restructured the class. All right, so common injuries, shin splints. Again, this is the tearing away of the periosteum or bone covering. I'm not going to go over all the causes and symptoms. You've already been tested on it. We know that if you don't take action and really focus on healing shin splints, that becomes a stress reaction and potentially later a stress fracture. Fifth metatarsal fracture, pretty excruciatingly painful, super common fracture that a dancer can experience. And again, this is, it can be a range of like supinating or sickling when on releve, that can lead to it. I was dropped and my ankle rolled as I fell. And that's how I broke my fifth metatarsal about 11, 12 years ago. Very common in dancers. We did not go over this one, so I just want to call your attention to it. This is the isfranc injury. So this is a strain, fracture, or dislocation between the tarsals, right? The tarsals are these bones, and the metatarsals, which are these bones. Yeah, and the most common is the third metatarsal in dancers. So let's go over that together. This is the first metatarsal. This is the second metatarsal, and this is the third, fourth, and fifth metatarsal. So you start with your biggest metatarsal, which is your big toe. That's your first, and then it goes all the way to 5 to the smallest one. So the most common is the third one. I would say the second most common is the second one for dancers, because that's where a lot of our weight goes in that releve. So causes can be a couple of options, right? So indirect causes include anything that involves articulation of the foot, but also twisting. Direct causes can include something heavy falling on the foot and dislocating it or cracking it. Symptoms include swelling of the foot, pain throughout the midfoot or this middle part of the foot, inability to bear weight, can't put any weight on it, bruising of the arch, and abnormal widening of the foot. So I've had a couple of dancers with this where their foot is like, all of a sudden it just kind of expands this way. It's really freaky looking. Treatment for isfranc injury: immobilization, which is wearing a boot 99% of the time. RICE, which is again, rest, ice, compression, and elevation. Anti-inflammatory drugs like ibuprofen or naproxen. Naproxen has to be prescribed by a doctor. Physical therapy, that's definitely going to be in the mix. At least 6 weeks rest, because again, bones take 6 weeks minimum to heal fully. And in some cases, surgery is needed if the dislocation or fracture is really, really bad. Osteoporosis, we've already gone over this. Isn't that nice? You already know this. And that is the end of our slideshow. Okay, everyone. So for our next course, we'll meet next Tuesday, and I will start the class with questions from this lecture. I know that normally I make space for you to ask questions throughout the lecture and at the end, just to make sure that we're on the same page with comprehension. I recognize that's not possible in this kind of asynchronous setting. So please, if I'm unclear in anything, just write down your question and I will take questions at the beginning of the next class on Tuesday. I hope you all have a great weekend. Bye.